بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. جماعة في new drugs that really emerge into the market in the last maybe 5 years and thus deal with the idea of hyperlipidemia. We already talked about 5 drugs used in hyperlipidemia. We talked about statins, niacin, fibrates, bile acid sequencers, and ezetimibe, and all those drugs are in the market for being longly. However, those drugs did not really offer a complete, coverage for all those patients with hyperlipidemia, neither through managing their situation or through really reducing the LDL cholesterol level toward the target that we need. Now, the merge or introduction of the new anti-hyperlipidemic drugs was in need, so we're gonna get this in need for hyperlipidemia. So we need to understand that those drugs are very important. موجودين في الأسواق في الأردن لسه ما دخلوا, لكن there's many of these drugs are in the market. Now, there's two types of drugs, generally speaking: drugs that are used to lower LDL cholesterol, and the other drug will be used for very low density or triglyceride reduction. So if we're talking about the familial hypercholesterolemia, that what we need, the LDL cholesterol lowering agent. The first drug is called bempedoic acid, and bempedoic acid is a nice name. It's used to inhibit another enzyme within the conversion of citrate toward the cholesterol. So that gonna remind us with the HMG co-reductase, and this MG co-reductase usually used, to inhibit to be inhibited through the statins. However, if we do something else, we inhibit the L enzyme, which is the ATP citrate lyase catalase. This is the enzyme. If we're gonna inhibit the conversion of citrate toward acetyl-CoA. So I'm gonna read now: ATP citrate lyase catalyzes the ATP dependent conversion of the citrate and coenzyme A to oxaloacetate and acetyl-CoA. Acetyl-CoA, the precursor of 3-hydroxy-3-methylglutaryl-CoA, is a crucial for synthesis of cholesterol, and you understand the rest. The rest gonna end up with inhibition of ACLY leads to a reduction of acetyl-CoA and cholesterol synthesis, resulting in an increased number of LDL receptors, causing a subsequent reduction of plasma cholesterol. As usual, inhibiting the cholesterol synthesis here gonna increase the LDL receptors to gather more cholesterol from the everywhere, from the, let's say, the LDL cholesterol within the blood, and gonna lower the LDL. We also gonna have to increase the HDL a bit to get back another cholesterol from the HDL, carrying the cholesterol from the foam cells toward the liver. And also, as we talked about at the end of last lecture, the stomach or the GI tract, the duodenum gonna increase the absorption of cholesterol, and we inhibited that increase by ezetimibe. So ezetimibe is a good drug also to combine with bempedoic acid, also as has been used to be combined with statin. So bempedoic acid is our drug, is a small molecule that act on the selective antagonist of this enzyme ACLY. It administered as a prodrug. This is a nice stuff, and require activation by very long chain acyl-CoA synthetase 1, which is an enzyme mainly expressed in the liver. So the acyl-CoA synthetase 1 is a enzyme that gonna activate our prodrug, and this is a bempedoic acid prodrug, and gonna be activated within the cell, and that gonna reduce the off-site target. So if you have a nice drug like this, it's gonna only activate it within the site of activity, and it's nice enough to be targeted toward the liver cell and to reduce the LDL receptors, and so to increase the HDL receptor, and so to have a lower cardiovascular event. In terms of efficacy, when we talk about efficacy of this bempedoic acid, generally speaking, it inhibits the LDL receptor, reduce the LDL receptors by 25%. it's actually it's 23 6 يعني around 25 24% من ال LDL. This is the maximum efficacy that we see. Maybe reach 30 بس مش زي الستاتين بقوة الستاتينز. statins is more efficacious than bibindiwic acid, and bibindic acid will have this special side effects. We have a problem with this drug, that the side effects as usual. It inhibit the transporter for the uric acid. Okay, so it will produce the following. It's gonna increase the blood urea, nitrogen, creatinine, and uric acid. Gout is an important idea here. Gout may happen within 3% of the population. We may have some muscle pain, although it's not much, and we don't know really that where from من وين جاي. But generally speaking, the side effects that you need to understand, which is a pharmacological side effects, is this one. Bibindiwic acid was associated with increase of blood urea, nitrogen, creatine, and uric acid, especially uric acid. It's also resulting in decrease in hemoglobin, meaning it may produce some sort of anemia. So bibindiwic acid is a nice drug, great drug. However, we have a special type of side effects here. We have an inhibition for the surrogate carrier, or the secretion channel that is gonna secrete those stuff, creatinine, nitrogen, uric acid within the kidney. The most obvious stuff that's seen in the clinical trial is the hyperuricemia and gout, and there's a little but we cannot neglect this. It decreases the hemoglobin, so it may produce what we called an anemia. So gout incidence was higher in bibindiwic acid group compared with the placebo group, meaning the placebo group will have 2% or 1.5%. The bibindiwic acid group, they had a 3.4 or 3.5% of this gout. Now we don't have to talk about this, but it does not produce a hyperuricemia, generally speaking. Okay, this is the bibindiwic acid. The first drug that we talk about is an inhibitor toward an enzyme, the upstream, the HMG coreductase, and it's have a nice activity, although it's not reaching the statin activity. We can add it toward the statin to have a better activity in lowering LDL receptors. Okay, that's it. This is bibindiwic acid. Now, another target that we're really interested in is the degradation of the LDL receptor, and the degradation of LDL receptor within the hepatocyte, which is a very interesting and rate limiting factor here, because what we do with the statin, with the other drug that we talked about just in a minute, we're reducing the synthesis of cholesterol, and that's gonna increase the HDL. How about getting a drug that really increasing the expression of LDL receptors without interacting with the synthesis, and without having hyperuricemia, without having the problem of myopathy and rhabdomyolysis and so forth, so on. We came up with another story. It's an inhibitor of PCSK. And what is this PCSK? This is an enzyme or enzyme. I'm gonna read now. It's called the proprotein convertase subthallicine كيسين type 9, an enzyme predominantly produced in the liver. موجود هذا بالليفر يا جماعة. bind toward شو بيعمل؟ bind toward LDL receptor present على السيرفس الهيباتوسايتس لما تكون receptors leading to degradation. يعني هذا إذا ارتبط في الريسبتورز بيؤدي إلى degradation toward إيش؟ toward ال LDL receptor. And this is the end result in increase the end result of increase the decrease the degradation of decrease the degradation of LDL receptors. If we decrease the degradation of LDL receptors, that meaning we're gathering more LDL cholesterol within the body, from the body of the patient, and we're reducing LDL. So thus inhibition of PCSK9 causes an increase in LDL receptor number and subsequent decrease in plasma LDL-C level. Now what we have drugs. Okay, what are those drugs? We have two mechanisms of action. for those drugs. We have an evolocumab and ilirocumab. Okay, and we will talk in a minute in another drug that called that is an siRNA inhibitor. Is its the name is inclisiran. Okay, all of them are inhibitors for this guy, and this guy is called PCSK9. Okay, this is the mechanism of action. You in normal situation, LDL receptors gonna bind toward the LDL cholesterol and will gather it down toward the liver. However, if you have this PCSK9 bind toward the LDL receptor, that gonna take it down toward the lysosome, and we will have lysosomal degradation of this receptor. If we inhibit this, if you see mechanism of action of all these anti-PCSK9 monoclonal antibodies and siRNA, you will have and end up with inhibition of lysosomal and increased number of LDL receptors, which is the stuff that you want. And you have this already with the statin and with the another drug that the benzoic acid that we talked about. Now, without producing all the other side effects of, it's the myopathy and the hyperuricemia within the benzoic acid. Okay, now quickly we're gonna talk about the same targets, however with the different mechanism of action, and this mechanism of action is a small interference RNA. So this small interference RNA gonna go in and inhibit the synthesis of this enzyme that result in inhibition, degradation of the LDL receptors. So the end result is the same. It's the same like the other drug that's as a monoclonal antibody. So inclisiran is a synthetic small interference RNA. Very nice. Now, what is this small interference RNA? These are sequence of RNA, double-stranded RNA. It's around بحدود 22 ل 26 nucleotide. How it work? Your target is gonna bind to your mRNA of your target. meaning إذا بدك أنت أي بروتين تعمل له inhibition في الخلية، أي بروتين موجود في الخلية بدك تعمل له inhibition، you design your siRNA and you get it into the cell and you inhibit the mRNA of the protein. How to do that? Small interference RNA. So inclisiran is a synthetic small interference RNA that work by targeting your drug, your protein. What's your protein? Is PCSK9 and is conjugated and the drug is conjugated toward something to carry it on and هذا إشي مش كتير مهم بالنسبة لكم، بس هذا الجال ناك gonna carry on the siRNA toward its target. So what is the end result? The end result is a very nice activity comparable with what? With the monoclonal antibodies we just talked about in a second, which is the BSK inhibitor, and these BSK inhibitors are a monoclonal antibody, two types, monoclonal antibodies and siRNA. Side effects, there's no side effects in reality for this small interference RNA. Very expensive drugs, cost 3000 JD. الإبرة بناخدها 3 مرات, we take it 3 times a week, 3 times a year. And the second as a loading dose, so this drug has a loading dose. However, and the same thing, monoclonal antibody is gonna have a loading dose, however less frequent, more frequent. And we end up with no side effects of monoclonal antibodies. So what is the side effects of monoclonal antibody? Flu-like syndrome. Okay, always when you give monoclonal antibodies, if you're giving BSK9 monoclonal antibody, you end up with flu-like syndrome, and this flu-like syndrome is it's gonna go within 1 week or something. Okay, so this is just to show you how does it work. Inclisiran is you see here double strand RNA, okay, bind toward GalNAc tail. We don't have to worry about this, but we need to worry about this. We get it in the cell, and when it gets into the cell, it will faced by something called RNA silencing induced silencing complex, which is the risk one. It's gonna open up راح تفتح ال 2 strand تعطيك 1 strand. هل ال 1 strand هذا is compatible أو compatible with your target. So هذا الأحمر شايفينه the red one here will go to your mRNA which is the mRNA of BCSK mRNA and will degrade it. And that means it will not be translated and you will not have this type of enzyme. And then having not this type of enzyme meaning LDL receptor will stay on. You will not have a lysosomal degradation for the LDL receptor as seen here on the right side and so forth so on. You will have more LDL cholesterol bind toward your LDL receptors and you're reducing the cholesterol level, so forth so on. So this is a very interesting new drug, new type of drugs, less frequent of taking drugs, very expensive. However, you will not really worry about the compliance. You remember the compliance and compliance and compliance. Remember this word, adherence of your patient toward drugs. لأنه كتير من المرضى ما باخذوا أدويتهم. وأنا امبارح زرت مريض ما باخذ أدويته، صار الإجكشن فراكشن 20%، اخذ مايوكارديك انفاركشن كانت قويه شوي برولافيوجين لانه ما اخذ الادويه. هذا الدواء الانسلسارين حتى المونوكلونال انتي بودي فور بي سي اس كي كمان بيكون بي سي اس كي 9 بيكون فيري نايس لانه بتاخذوا ليس فريكوينت ومش اورال دراجز اند سو فور سو اون. they can be taken with statin to increase the activity of statin and so forth so on. So that's the end of this. Now, the last drug that we want to talk about is a drug that deal with ApoC3, and this is more toward the triglyceride rather than toward what we called that's a triglyceride drug rather than an cholesterol drug. So gonna reduce very low density lipoprotein and gonna reduce the triglyceride and even gonna reduce the chylomicron. Why is this? Because apolipoprotein C3 is a key regulator of triglyceride metabolism. I'm reading now again. Apolipoprotein C3 is a key regulator of TG metabolism. It's a potent inhibitor of lipoprotein lipase. So this ApoC is an inhibitor for lipoprotein lipase. So our target now is a lipoprotein lipase, the enzyme responsible for the lipolysis of triglyceride in a very low density lipoprotein and chylomicron. So what's this? ApoC is an inhibitor for lipoprotein lipase. And this lipoprotein lipase gonna hydrolyze or lipolysis produce responsible lipolysis of triglyceride in very low density lipoprotein. So if we inhibit the inhibitor, that's gonna be very nice. We're gonna increase the lipolysis of triglyceride and that's in the very low density lipoprotein and in chylomicron. So what's the result? The result is reduction in triglyceride and result is a reduction in triglyceride generally speaking. Where to use this? We're gonna see in a minute. Now, how did we know this? We understand if your patient have this loss of function mutation إذا كان عنده polymorphism في الانزيم اللي اسمه ApoC3 اللي هو responsible for ApoC3 which is a component of the lipoproteins generally speaking. If you don't have it or your patient don't have it, that means he will have less 40% triglyceride and less 40% of cardiovascular diseases. And this is where we want to see this. يعني من وين جبنا الفكرة؟ جبناها من إنه إذا صار ميوتيشن في هذا الإنزيم ده مين إنه الإنزيم بطل يشتغل، بطل موجود. فليش ما إحنا كمان لما يبطل موجود بطل ما يكون active في يكون عندنا 40% lower plasma triglyceride and 40% risk for cardiovascular disease, especially إذا كان cardiovascular diseases ناتجة من ال very low density lipoprotein generally speaking. So what to do? Inhibit this through an inhibitor for ApoC3. And this is the drug, a very interesting drug called volanisoren. Volanisoren is an antisense again. What is this? This is antisense oligonucleotide. Okay, it's a small interference RNA as we said before, like the drug that we just named inclisiran for the BCSK9. This is another antisense drug, and Folaneserensin has been tested in patients with elevated plasma triglyceride level and in patients with familial chylomicronemia syndrome and autosomal recessive disease of chylomicronemia metabolism. ارجع للسلايد اللي احنا شرحناه بالاول بتعرف عن ايش بنتكلم. In 2019 volaneserensin was approved by European Union for treatment of adult patient with this familial chylomicronemia syndrome. However, we use it also في المرضى اللي عندهم hyper triglyceridemia. Common side effects now you need to understand. Now this is a problem caused thrombocytopenia. It's not very very common. However, it's there with a little incidence if you like. And injection site reaction is injectable drug is a small interference RNA for so on. This is again prevention of formation of ApoC3 by second generation antisense oligonucleotide, meaning a small interference RNA. We get it in, we have it, usually it's double strand, gonna go, we have this, the disk that we talk about, the disk complex gonna open up the small interference RNA, gonna reach your mRNA, inhibit the expression of your mRNA, and what's the mRNA now? It's not the BCSK now, it's ApoC3, and the end result is the reduction of what we call a reduction in the ability, reduction of the reduction in the activity of the ApoC3 and the reduction in triglyceride at the end of the day. The last drug we're gonna talk, it's all about the other drugs. The last drug we're gonna talk about is the NGPLT inhibitor, and this is the last one. And what's the NGLT3? Generally speaking, it's the regulated plasma triglyceride and HDL-C level by inhibiting lipoprotein lipase again and endothelial lipase respectively. Now, inhibition of AGPLT preserved the function of lipoprotein lipase and endothelial lipase with a subsequent decline in triglyceride, LDL and HDL. However, it's generally has the actor activity على الtriglyceride plasma dependent. Now we working independent of LDL receptors يعني مش زي الستاتين. Therefore it was proposed to blocking ممكن احنا نسكن NGLT and reduce the cardiovascular event. Now the drug called Evanacumab, it's a monoclonal antibody neutralizing level in the serum. However, it has this influenza-like effect. And if we do this, we're gonna reduce the triglyceride LDL receptors and so forth so on. نفس الشيء. Evanacumab is a monoclonal antibody. However, there's another inhibitor for NGPLT3 called vobonorsen, is antisense, the same thing. antisense meaning it's an siRNA زي ما شرحنا قبل شوي, بس التارجت نفسه NGPLT3. And I think that's all. In terms of side effects, they don't have side effects except if we have this monoclonal antibody, you will have this influenza-like effect. It's toward triglyceride rather than the LDL receptors, and it's really also level the LDL receptor around and have a nice activity toward the cardiovascular activity. Now بس عشان نكون واضحين, احنا الأدوية هاي ال NGPLT3 inhibitor وحتى ال BSCK9 inhibitor وحتى ال ApoC inhibitors كلهم لهم activity, لكن الستاتين يبقى هو الأساس في treatments. فهدول الأدوية راح يكونوا add on drug rather than a new drug, generally speaking. Okay, and this is the last slide. It's the ENGBTL. You have different way of reducing the expression of this enzyme, and and this enzyme is important for the lipoprotein lipase that found in the body. We don't really use it yet, بس خلوه معاكم تكونوا عارفين شو هو. وهيك بنكون خلصنا محاضرتنا الأخيرة, وجزاكم الله كل خير ويعطيكم ألف عافية يا جماعة, وشكرا لكم. طبعا هذا السلايد بلخص لك كل النيو دراجز، لكن يعني بس هذا جايدنس لانه في ادويه ما شرحناها within هذا السلايدز. وجزاكم الله كل خير ويعطيكم الف عافيه، وشكرا لكم على تعاونكم، واسفين جدا على التاخير في تنزيل هذه المحاضره، لكن اي ثينك انها يعني محاضره قصيره، وان شاء الله ربنا بيسر امركم، وجزاكم الله خير، وادعونا في ظهر الغيب. شكرا جزيلا.